everyone. Getting this video in a little bit late. It's just been a crazy week with all the weather and not having water for 4 days or electricity and very spotty internet connection. So I am finally back at work and able to finally get this done while I'm here at work. So I did have a pretty interesting case that I encountered last week. A patient came in. He was an 84-year-old man who came in with chief complaint of weakness and shortness of breath. He was recently admitted to a nearby hospital about a month ago for a syncopal episode, which ultimately ended up resulting in a diagnosis of a very rare neurological condition called CLIPPERS, which stands for chronic lymphocytic inflammation with pontine perivascular enhancement responsive to steroids. It's a mouthful. So the patient was admitted to that nearby hospital for about 2 weeks and had an MRI done, which confirmed the diagnosis. And the patient stated that beside the syncopal episode, the only other symptoms that he noticed was that he was having progressive generalized weakness. He was given steroids in the hospital, and even though his weakness did improve, he was still not able to be independent with his ADLs, and so he was ultimately admitted to a facility, for which unfortunately he ended up acquiring pneumonia while there. So he ended up coming into us for increasing shortness of breath, like I mentioned. And he did a chest x-ray, which showed a right lower lobe pneumonia. And he was also noticing that he was having increasing oxygen demand. He did have a history of COPD, so he was on a baseline 3 liters nasal cannula of oxygen at home, but he was noticing that he was desatting more and that he was requiring more oxygen. So he ended up being admitted to us for IV antibiotics to treat the pneumonia and also for PT-OT eval, which was done, that showed that he did have very significant weakness still. He ended up being discharged from us to a rehab facility with oral antibiotics and prednisone for the CLIPPERS disease. So just wanted to go over some information in regards to the CLIPPERS disease. Like I mentioned, it's a very rare chronic inflammatory neurological syndrome that affects multiple regions of the brain, including the brainstem, the cerebellum, and even the spinal cord. It's fairly new. It was actually only first recognized in 2010, believe it or not. So the big hallmark on neuroimaging for CLIPPERS is that there's multiple punctate patchy lesions and linear regions of contrast enhancement, and most notably peppering, so to speak, of the pons, which spreads to other areas of the cerebellum on MRI. So this patient did have an MRI at the original facility, which confirmed this diagnosis. Clinical presentation of CLIPPERS is pretty variable. The symptoms are typically subacute. They're progressive and episodic, so it makes it very difficult to diagnose this. There's usually a lot of things around the differential diagnosis when you're trying to figure out what this is. However, once it is identified, it's extremely treatable with long-term steroids. So it's important that early recognition and starting treatment is done to reduce the morbidity and mortality, because if it's not treated, these patients just get progressively weaker and weaker and weaker to the point where they can't even function. It presents in a wide range of patient ages, anywhere between the ages of 13 and 86. However, it is generally seen in middle age, and there is a predisposition of what they're seeing for increased risk from the male sex. So like I mentioned, the clinical presentation is typically subacute, and the signs and symptoms have a pretty wide variety, but it's mostly dominated by cranial nerve dysfunction, which can present as slurred speech, altered facial sensations or double vision, cerebellar signs such as ataxia, and long tract signs such as muscle spasticity and altered sensation. The pathology behind this condition is pretty poorly understood, but some type of autoimmune mediated or another inflammatory pathogenesis seems to be what is being proposed as the etiology. Patients typically respond pretty rapidly to the administration of glucocorticosteroids, but they do have a tendency to relapse if the immunosuppression is stopped. So it's very highly recommended that they continue with long-term immunosuppressant with steroids. So perhaps that's what happened with this patient, is that after he was discharged from the hospital, he did not continue with his steroid treatment. I'm not really sure, but he was incredibly weak, even having been initially treated with IV steroids when he came to us. So we gave a lot of education on the importance of continuing his steroid treatment, and of course, all the side effects that can go along with that. Particularly, making sure we're not just suddenly stopping them, or, making sure if we are going to try to go down, we taper. So all that good stuff. So just thought this was a pretty interesting case. This was a condition that I had never heard of before. So yeah, pretty cool one. So let me know if you have any questions or have any other information about this. Excuse me. Thank you.